I'm joined today by Sara Richards, our Assistant Vice President of Nursing. She has a variety of nursing departments that report to her, but today we're going to be talking about something that's near and dear to both of our hearts, our emergency department services, and a whole series of questions that we probably have thought about but never really heard anybody explain, like when do you choose to go to an emergency department versus go to an urgent care? And what happens in an emergency department, and what kind of things can we do? So I've got a few questions for Sara, and again, welcome and thank you for joining us today. Let's start off with that burning question. Urgent care versus ER. How do you decide between the two?
So I have in my lifetime worked in urgent care before. In my experience, what I've learned is that you don't necessarily get the same, I don't want to say quality, but you don't get the same services in an urgent care that you would in an emergency room. For instance, your physician that may be there, they are not sometimes specialized in emergency medicine. It may be an allergist. It may be a family practice doctor. You don't know what kind of background. It may not even be a
doctor. It could be a nurse
practitioner. Correct.
Okay.
And along with that, the other professionals that are taking care of you, they may not be nurses. They may not have RN or LVN behind their name. They might be a medical assistant. It might be a CNA. And there's nothing wrong with that per se, but when you're sick and you're ill, the person giving you medicine, you would like them to know exactly why they're giving you the medicine, not just because it's an order from a physician. And that's really a big difference between what nursing can do and what medical assistants and CNAs can do.
So we use the term medical assistant, and we all understand what that means, but tell me what's the education of a medical assistant as compared to an RN?
Medical assistants generally have their either GED or high school diploma.
Okay.
And they've gone through maybe a 9-month course, learning how to do skills, like certain laboratory tests. They learn how to draw blood. They learn how to administer IM injections. And that is pretty much it.
Okay. So they can do a blood pressure. They can, can they you put an EKG on me or something to that? They can do things like that. So all those things a nurse can do. So a nurse goes through a minimum of 2 years of college level education?
2 years plus 2 years of prerequisites just to get the basic associate's degree.
So it's 4 years to get an associate's degree?
Correct.
Well, I always thought it was 2 years. Well, that's something I learned today. So it's a 4-year college degree that gets you an RN that enables you to practice. Okay, so they can do everything that the medical assistant can do, and then what more can they do? What are they licensed to do above that?
That is pretty much it.
No, a nurse.
A nurse. Okay, so
I hope a nurse can do more than that.
A lot more. Nursing, we're taught how to critically think. We're also taught to always question. So just because I have a physician's order does not necessarily mean that I blindly carry it out. I have to know why I'm giving what I'm giving. I have to know how it's going to work in the body. I have to know what am I looking for in my patient that I should be concerned about. Okay. I also have to know how maybe an allergy that you may have may cross over into this medicine that I'm giving you. So I have to watch for that. So we always have to question. And it's not just our physicians, it's also our pharmacists, because we're all human beings. Everybody might make a mistake. So that's why we're trained the way that we are, so that we can go back and we're that stopgap between a possible mistake happening. And it takes the entire village to do that, the entire hospital to do that. We're also trained in ACLS in the emergency room.
And ACLS means what?
Advanced Cardiovascular Life Support.
Okay.
So,
and in layman's terms, what does that mean?
That means if you come into the hospital and you, God forbid, have a heart attack and your heart stops, we have been trained very extensively how to help you regain consciousness.
So you're going to save my life?
Save your
And you're
life.
telling me an MA doesn't have those skills?
They can do the compressions, but they
Okay.
cannot
I
push
could
the
do
cardiac
compressions.
drugs.
Okay, can't put. So nurses are also licensed to handle a whole, virtually every drug that we administer to our patients is administered by a nurse. And there's for an an RN, there's no limitation on the drugs that they can administer to the patient that are ordered by the physician. Is that
In an
correct?
emergent situation.
Okay.
Yes. So, say if we're doing a moderate sedation and it is not life saving, right? So, say you have somebody that comes in with a broken arm.
Okay.
If you have a pulse on that arm, it's not truly a life or limb saving emergent situation. So that drug that we would give you to put you to sleep temporarily or put you in that twilight state, the physician would have to give you.
Physician.
The
Okay.
physician.
Okay.
But if you don't have a pulse in that arm, that means that we have to get it corrected as quickly as humanly possible. And in that situation, with a physician present, the nurse can push that drug.
You've confused me, and
That's okay.
That's okay, though. I'm sure a lot of us are confused by this crazy healthcare system that we have to periodically involve ourselves in. Okay, so in the urgent care center, I've got MAs potentially. I might have LVNs, which is a lower level nurse. They have restrictions compared to RNs.
Correct.
Right. And I might have a doctor. I might. It's probably not an emergency medicine doctor.
Correct.
It's probably a doctor that has some other specialty. Generally speaking, I imagine family medicine.
Usually.
Okay. And so I happen to know this answer because my son is an ER doctor, but emergency physicians are specifically trained in emergency conditions. So if you come in, no matter what you come in with, from having a baby to having a heart attack and everything in between, emergency department physicians are trained to handle those situations. Family medicine doctors, on the other hand, have a training that is related more to what you would see in an outpatient setting, in a clinic setting. It's non-emergent sort of issues. So though they may be familiar with the concepts that an emergency department has to handle, they're not specifically trained in that. They may acquire those skills over the years. Mm-hmm. That's possible, but not generally in an urgent care center would they have acquired those skills. They would have had to acquire them in an emergency department, and then they probably, if they have acquired them to the point that they can function in an ER, they're probably not working in an urgent care center because Correct. The urgent care centers don't pay as much as ERs, do they?
Correct.
Ah, interesting. Okay. So you got more highly trained staff and more highly trained physicians in an ER versus an urgent care. So would there ever be a situation where an urgent care would make more sense?
It depends. If you are an educated individual about your own health and you have an established issue that you know, for instance, say you're somebody that gets a UTI, you know what it feels like.
UTI, urinary
tract infection.
Okay.
You may decide to go to an urgent care because you don't want to go to an emergency room for something that you know is going on with your body and you feel fine. You just know it's coming on. That would be perfectly acceptable. But if you're not educated about your own health or about your own body and you're not really certain about what is going on, I would always recommend that you go to an emergency room. Because something very small to you might be something very, very big that you just don't know about. And it could save your life. So that's would always be my recommendation.
So you've also worked in freestanding emergency departments, have you
Correct.
not? Okay.
Mm-hmm.
And so they seem to be on every corner, a freestanding ER.
Correct.
And so I think I know the answer, but what's the difference in capabilities of a freestanding ER? Now these have ER docs, right?
Yes.
But not always.
True. Most of them have to have either emergency board-certified doctors.
They have to have a board-certified doctor, but it doesn't have to be somebody boarded
Exactly.
in emergency medicine. It can be a family practitioner
It could be.
that works in that setting. And is that 50-50, or do you find more ER docs there, or
It's about 50-50, I would
Okay.
think. Yeah.
So you don't really know when you're
Correct.
going into that. And it could be on one shift they have an ER doc and another shift they have a family medicine doc that's been working in that setting. Not to say they're not capable of it, but it's a different level of expertise.
Right.
Okay, so you go in, and so what capabilities do they not have that a hospital does have?
The biggest one that I can think of is just simply the admission process.
Okay,
Getting you admitted to a hospital, it's always a transfer.
okay,
And then in most situations, if you're to be admitted to the hospital and they've got to get acceptance from another hospital, there may be a longer wait for you to actually get into a hospital bed because they've got to call an ambulance, they've got to get administrative approval from the accepting hospital. And whatever's going on with you, that hospital may not have the bed capacity to give you. So
okay.
you may be holding, and you may end up right back in their ER holding to get an admission upstairs.
Now, do these freestanding facilities have access to specialists like cardiologists, pulmonologists,
Not
infectious
usually.
disease?
They have to go with, if they get an accepting hospital, they can contact their consults.
So you're relying, as a patient, you're relying on them diagnosing that your condition requires a specialist, like a neurologist if you're coming in for a stroke or stroke-like symptoms, or a cardiologist if you're coming in for a heart-related issues, or other physicians if you're coming in for lung-related issues. You're going to need to see a pulmonologist. All of these things are going to require that you go to the hospital.
Correct.
For them to get access to the proper specialist for your care. How about a kidney stone? Can they treat a kidney stone?
Depends on how small the kidney stone is.
So that's a matter of passing it. But if treatment is required, you're going to have to go to the hospital.
You're going to have to be in the hospital.
It's a lot of things that you can't get in a freestanding.
Right.
So when should you go to a freestanding? It is an ER. They bill me like an ER.
It is an ER. I would say that if you were in an area where you didn't have a local hospital near you within a little bit of time, then, and if the freestanding is right there and you feel like you have an emergent medical condition, that would be when you go, because they do have the same nurses that we have at the hospital. They all have to have ACLS.
Okay.
They know how to use the emergency drugs.
Okay.
The physicians are all trained the same way. But if you can make it to a hospital that has all of the services that you may need, I would go there.
How about a sprained ankle or something like that? That would be appropriate for a freestanding?
Yes. However, in my experience, sometimes sprains, what you think is a sprain, is actually a broken ankle.
Then I need an orthopedic surgeon to diagnose and decide the proper course of action there.
Right.
Very confusing if you're not knowledgeable about these things. And then ERs are sometimes a very expensive option too. So, I mean, freestanding ERs can be a very expensive option. Okay. What symptoms or situations do you wish more patients would recognize as a true emergency?
Strokes.
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 Not heart attacks, strokes.
Strokes.
Okay, tell me more about why. How would we recognize when we are suffering stroke or stroke-like symptoms?
So we have an acronym for that. Be fast. Okay. So the B is for balance. Okay. If you're all of a sudden dizzy, you have vertigo, and it's unusual for you. And it usually comes on pretty suddenly. That is one sign of a stroke. It's not just dizziness. You should probably go get that checked out. E is for eyes. So all of a sudden you don't have vision, or you only have partial vision, or you can't see out of the sides of your eyes. That should be very concerning to you.
Okay, I've heard about that.
F is for face, so facial drooping. And sometimes that's very subtle, very, very subtle. Usually it's a loved one that says, hey, mom's face just, she can't do everything that she was doing. I'm concerned. A is for arms. So, and it's not just the arms, it's the legs as well. So if you're suspecting a stroke and you have your person hold out their hands, they can't hold them at the same level. They're weak, basically, in one area or more. That's concerning as well. Our S is for speech difficulty. So if all of a sudden you have slurred speech, or they're drooling, that's another thing, or they're hard to understand, that's a big deal. Okay, that should be checked out immediately.
Okay.
And then time. We put the time in there because it is very time sensitive. It's crucial that you get to a hospital where we can give you the medication to break up that blood clot that's in your brain as quickly as possible. But we're timed on it, right? So we want to know the last time you were normal. Okay, pin it down as close to the time as you can. When's the last time you were last seen normal? We've got about 3 hours to get that medicine into you so that we can get you back to your baseline.
My baseline means
You're normal.
my normal? Okay.
Yes.
All right, cool. Okay. So I'm guessing that you want us to be aware of these because they're less well recognized. Like everybody knows chest pain is a sign of a heart attack, and therefore I need to get into the emergency department. But on the topic of heart attacks, don't women show different symptoms for a heart attack than men do?
Yes, we're built a little bit differently than men.
So I heard somewhere that like indigestion is a common, it commonly accompanies a heart attack in women more so than in men.
Yes.
I mean, but indigestion, everybody has indigestion periodically. How do you differentiate between a heart attack, which is really bad, and just normal indigestion?
So not everybody gets indigestion.
No?
No, not everyone.
Darn. I'm just one of the lucky ones.
You're one of the lucky ones. But that's a very good question. And it's not always the hallmark thing for us as women to recognize, you know, because I do get indigestion. I wouldn't know. I would take a Tums.
Right.
But I would be concerned if the Tums that always works for me all of a sudden
and maybe it's persistent. Yeah, it doesn't go away. Okay, I'm doing the things normally that resolve it, and it's not going away. I better check. I better get into not a freestanding ER. Go to an ER, because if you think you've got anything significant like a stroke or a heart attack or otherwise,
time is tissue.
Time is tissue. Okay.
It's just like a heart attack where it's a blood clot that is preventing blood flow. It's the same thing that happens in your brain with a stroke. There's a blood clot in there. It's preventing blood flow. Okay.
So what I have learned is that I potentially, in an urgent care setting, might have somebody that has less than 1 year of post-high school education versus minimum of 4 years in a hospital emergency department. My physician might not even be a physician in an urgent care center, might be a nurse practitioner versus an ER trained physician in the hospital. Even in the freestanding facilities, while I'm going to get the same nurses and doctors, not always necessarily an ER doctor, but working in that setting, but I'm not going to have access to all the tools, the specialists that a hospital has.
Right.
Okay, and the medications. And there's no pharmacy in either the freestanding ER or the urgent care center to verify the medications are appropriate. Is that a correct statement?
That is correct.
Wow. Okay. And I might pay more for all of that in a freestanding ER than I do in the hospital. How interesting this is. Well, let's go on down to the ER and let's check it out and continue our conversation there. How's that sound?
That sounds good. Joe, you got to leave your cup here.
Really?
Yeah.
Why is that?
Because we're going into a clinical setting. And so we can't have food or drinks out.
Even the CEO?
Even the CEO. It's not that special. Got to put it up.
Okay. Okay, so Sara, tell us a little bit about where we are right now. And if you could, since we're talking about an ER versus an urgent care, show us some of the things that are in this room that you're not going to find in an urgent care facility. Or, I mean, you may find them in a freestanding, but certainly let's talk about urgent care.
Okay. So right now we're in one of our trauma rooms here at our Jackson Street location. And some of the equipment that we have in the room, we have, of course, the Broslow cart over here. We use that for any pediatric emergencies that come through. If we have a child that needs to be resuscitated for whatever reason, everything that we would need is inside that cart.
Would that be in an urgent care center?
Sometimes it's not guaranteed.
Okay. You wouldn't typically find it, what we call a PD cart in a physician's office, would you?
No,
Okay. So it would be probably unusual to find it in an urgent care center, I imagine.
most likely.
Okay.
And even then, if you did have one, the only person that might know how to use the equipment inside is the physician or the
Okay.
NP.
Or the NP. Okay. Very good.
And then we have over here, we've got a baby warmer is what I call it.
Mm-hmm.
So it's for a baby that, a mama that may not be able to make it to a labor and delivery place. We've birthed some babies in our emergency room here.
So I imagine that's not something an average urgent care center can do, is deliver a baby.
No, and there's more to delivering babies than just here you go.
Catching the baby?
Yep, we've got to do a lot of stuff to make sure that they're healthy. So
that makes sense. Makes sense. Good
that
to know.
keeps them warm.
Okay.
And then back here we have our oxygen delivery system. We have suction there. We also have our cardiac monitor up here that monitors your vital signs, your heart
rate. And I don't
rate.
imagine any of that is in
not
an
in an urgent care
center. Okay,
not
so we don't have suction, we don't have oxygen, we don't have air.
Right. We also have, this is our bear hugger. So it is for people who are hypothermic, which means their body temperature is too low, sometimes inconsistent with life. We can use this to help warm them back up. And we also have our adult crash cart back here for any adult that may come through that needs resuscitation.
Wow. That's an impressive array of tools that we have here in an emergency department that you might not find in an urgent care center. Now, would you have these same capabilities in a freestanding ER?
Yes.
Okay, so they're going to have suction and air and oxygen. Will they have cardiac monitoring?
Yes.
Okay, so they'll have that. So they'll be able to stabilize me, but if I need any higher level of care, any specialist attention or otherwise, then they're going to send me to a hospital, and I'm going to get in the queue, and time can very well have an impact on kind of how my outcome comes
out. Not only time, but also the ambulance ride there.
Yes.
Because that's factored into it as well.
Okay. All right. Very good. Now, I'm going to answer this question. The cost issue of an urgent care, which tends to be much lower cost, and then freestanding, which is your highest cost, because in many cases your freestanding facility is out of network. Out of network means that they're not inside your Blue Cross network or your United network or your Aetna network, and that means that they can charge you whatever they want to charge you, and then you have to negotiate. Your payer has to negotiate with them a payment, which can, dependent upon your plan, be more expensive than an in-network ER hospital, and most hospitals are in network with most plans, I imagine. So then the whole cost equation kind of gets really disruptive to the decision. We shouldn't be thinking about the cost when we're having an emergency. Right. I don't imagine.
Right. Yeah.
As a nurse, you would say, "Joe, don't worry about the cost. We'll deal with that later.
We'll take care of you." In an urgent care setting, it's not supposed to be for emergencies.
Right.
It's supposed to be for very low acuity things.
It's like when you would go to your normal doctor on an appointment, but they're closed, and you don't feel like you should wait until they open up on Monday, for example.
Right, exactly.
Okay.
So just like your doctor's office, where they expect you to pay your insurance copay.
Yeah.
Same thing in the urgent care setting. Before you see a doctor, before you take any tests, you usually have to pay your copay.
Gotcha. So we don't do that in an emergency department.
We cannot do that in an emergency department.
We're obligated to treat whomever comes in here, no matter what their insurance is.
Correct.
And that's the law.
That is the law.
Okay. Very good. And so last question, can you recall a situation where a person came in here maybe after going to an urgent care center, and it led to a worse outcome?
So I can tell you a story that happened to someone that's in my family.
Okay. So there's no HIPAA here. It's your
There's no
family.
HIPAA here.
Okay.
It's my family. Flu season. Went to urgent care. Of course, didn't have the flu. Fever, all the symptoms, and I'm thinking, because I'm a nurse, I'm like, okay, it was a false negative, right? They maybe didn't go far up the nose as they should, or didn't collect the right sample. A few days go by, fever is still there, doesn't go away, but this person also has an underlying medical condition that puts them more at risk for infection. And I come home one day.
This doesn't sound good.
This person is wearing shorts, and I see a circumferential rash on his lower leg.
A circumferential rash?
It's redness that goes all the way around a limb. And in emergency medicine, we know that's an emergency. That's real bad news. Okay. So I ended up taking him to an emergency room where he was diagnosed with sepsis.
Sepsis is a blood-borne infection.
Yes.
And it can be life-threatening, can it not?
It can, and it can happen very rapidly.
Oh, wow.
So he was not in septic shock yet. He was in severe sepsis.
Yes.
So we narrowly escaped an admission to the hospital, and that was only because I'm an RN. And they could trust me to make sure he took all his medicines, but he had to stay through a couple of rounds of antibiotics first. So.
Wow. Yeah, I've known otherwise healthy people who get sepsis, go into septic shock, and die within 24 hours.
Right.
Otherwise healthy.
Yes.
It's not something to mess with.
It is not.
Okay.
It is not.
All right. So is there anything else that we should know about how to make a decision on what emergency department, what place we should go to when we think we need immediate care?
If you think that you need emergent immediate care for whatever reason, if it's an emergency to you, I would always tell you to come to an emergency room where you have all the equipment, you have all the people that are trained, you have emergency room physicians taking care of you. Even if it's something minor to you, it may not be that something minor that you think it is. It might be the flu that's really sepsis. So I would always encourage you to come to the emergency room if you are unsure about what's going on with your health.
And you have insurance, and if you don't have insurance, we're still going to take care of you.
That's right.
Okay. Well, thank you very much for joining us today, and we look forward to another conversation. Sara, thank you so much. This was really informative. I learned some new things. I learned from all these blogs, but thank you for joining us, and we look forward to seeing you on another Cup of Joe.